Grief, loss, and palliative care. Clients experience loss in many aspects of their lives. Grief is the inner emotional response to loss and is exhibited through thoughts, feelings, and behaviors. Bereavement includes both grief and mourning, the outward display of loss, as the individual deals with the death of a significant individual. Palliative, or end-of-life care, is provided by nurses to meet the client's physical, spiritual, and psychosocial needs. End-of-life issues include decision-making in a highly stressful time, during which nurses must consider the desires of the client and the family. Healthcare personnel can assist clients with end-of-life decisions to enable a smooth transition during this time of stress, grief, and bereavement. Advance directives are legal documents that direct end-of-life issues. A living will is a directive document for medical treatment per client's wishes. A healthcare proxy, also known as a durable power of attorney for healthcare, is a document that appoints someone to make medical decisions when clients are no longer able to do so on their behalf. Types of loss. Necessary loss is a loss related to a change that is part of the cycle of life and is anticipated but can still be intensely felt. This type of loss can be replaced by something different or better. Actual loss, any loss of a valued person, item, or status, loss of a job that others can recognize. A perceived loss is anything clients define as loss, but that is not obvious or verifiable to others. Maturational or developmental loss, any loss normally expected due to developmental processes of life. These losses are associated with normal life transitions and can help people develop coping skills, like a child leaving home for college. A situational loss is any unanticipated loss caused by an external event. A family loses their home during a tornado. And an anticipatory loss is experienced before the loss happens. Although grief is a normal response to loss, every person has their own unique way of moving through the grieving process. Grief theories and models have been developed as a means of providing an explanation and guidance in anticipating how a person may cope and adjust when experiencing grief and loss. In addition to these grief theories and models, researchers have identified some other common responses to grief that clients may experience. One of the best-known grief theories is Kubler-Ross's 5 stages of grief. This model is named after the psychiatrist Elizabeth Kubler-Ross, who initially developed the theory for the dying in 1969. Her theory was quickly adopted by therapists and other healthcare professionals to understand the grief process. The Kubler-Ross model identifies 5 stages in the grieving process: denial, anger, bargaining, depression, and acceptance. Originally, it was believed that those who were grieving had to go through all 5 stages in a precise sequential order. Later, Kubler-Ross revised the theory, stating that the 5 stages were not sequential and an individual may not necessarily experience all of them. In other words, an individual may go through 3 stages or 5 stages or may bounce back and forth between stages. Denial, in which the client refuses to believe reality, is the first stage in the Kubler-Ross theory and is an attempt to lessen the pain of the loss. In this stage, it is not uncommon for the client to have a feeling of numbness and shock. The mind is trying to adjust to a loss of someone or something and wonders how life will continue in this altered state. The client is trying to understand what has happened and deal with the feelings of losing someone or something. Denial is a time in which the client reflects on and relives the time spent with a person and questions how life can move forward without the person. It is the body's way of slowing things down and giving time to adjust to the loss so that the client will not become emotionally overwhelmed. Anger is the second stage in which the client is trying to adjust to the loss and is feeling severe emotional distress. The client thinks, "Why me?" and "It's not fair." If clients have a strong religious faith, they may question their belief in the deity. Is it normal to feel angry after the loss of someone or something? It is. Anger provides a means of releasing emotional discomfort. Blaming of others for the loss can also occur, with anger being targeted at loved ones such as family and close friends. Anger is a necessary and healthy stage of grief. It will eventually dissolve, and the more anger that is felt, the faster the person will heal. After a loss, many people feel abandoned and left alone. The feeling of anger connects the client to reality, and it is something that will connect the client to people once again. Bargaining is the third stage as the client tries a different approach in an attempt to relieve or minimize the pain felt from the loss. Usually, clients try bargaining with a higher power by making a promise to do something in exchange for a different, better outcome. For example, I promise I will be a better person if you let this person live. This response is an attempt to avoid grief through the act of negotiating. In this stage, guilt is also commonly experienced as part of the bargaining stage. The client worries, if only I had driven them to work that day, they would still be here today. Depression is the fourth stage, the stage where reality sets in and the loss of the loved one or thing is deeply felt. The realization that the loved one is gone or the situation is over becomes real. The client feels numbness and a sense of immense loss, mourns the loss, and wonders if it is worth continuing in life alone. Some clients might withdraw, not wanting to be around others as they try to deal with the loss. It is natural and appropriate to have feelings of depression during the grieving process. Acceptance is the last stage in the Kubler-Ross theory of grief. It is the point at which the person still feels the pain of the loss, but realizes that all will eventually be well. The person acknowledges the new reality, such as a spouse or child who is never coming back or a job that they will never return to. Some days will be better than others, with a higher number of good days versus bad days. In this stage, the person begins to connect with friends again and may perhaps make new friendships. The person recognizes that nothing will take the place of the loss, but that life goes on. Manifestations of grief. Grief can be defined as the feelings or reactions that an individual has to a loss in their life. The loss that an individual faces is not always related to a death. Indeed, grief can be experienced with many types of loss. Every person experiences grief in their own unique way. Characteristics and responses of an individual experiencing grief and loss are explored through the lens of various theories and conceptual frameworks. These theories and frameworks provide the nurse with the necessary knowledge to meet the needs of the client who is affected by grief and loss. This will also explore factors that influence a client's response to grief and loss, such as age-related considerations, cultural influences, and spiritual influences. Lastly, nurses' own experience of grief and loss when caring for clients and families facing a loss is explored, including approaches to self-care. Types of grief. Most individuals, if not all, will experience grief at some point in their life. Grief is an expected process that clients experience after they have suffered a loss. The American Psychological Association defines grief as the anguish experienced after significant loss, usually the death of a beloved person. This sensation is experienced when someone or something that a client has a deep connection with is lost. Grief can occur after receiving bad news about one's health or from many life situations. A client may experience grief due to the loss of a loved one, such as a spouse, a parent, a sibling, a child, or a close friend. Other examples of losses that may trigger grief include divorce, retirement, loss of a job, loss of friendship, loss of financial stability, a miscarriage, or moving to a new city. Grief can include both emotional and physical manifestations, and it is usually accompanied by physiological stress. Clients may exhibit anxiety, difficulties in concentrating, thinking about the past excessively, and agitation. Just as there are different causes of grief, so there are different types of grief that clients may experience in response to a loss in their life. Grief is the body's way of healing after one has suffered a loss. Normal grief, also known as uncomplicated grief, is caused by the loss of a loved one, through death or the ending of a relationship. In addition, grief can be triggered by other experiences that are considered to be painful or traumatic to the client. Although the period of time for which an individual grieves a loss will differ for every person, most people will experience grief after a loss for several months to a year. Nevertheless, it is essential to remember that normal grief is different for everyone. Individuals' display of grief is as diverse as the individuals themselves. Grief is experienced differently by everyone, as an individual's sense of loss is unique to that person, and people's feelings regarding loss reflect their own unique makeup. Feelings experienced during grief often include sadness, guilt, yearning, anger, and regret. There is no timeline for how long an individual will experience grief, nor is there an ordinary degree or severity to which an individual will experience grief. Grief typically lessens over time as feelings decrease in intensity, and the person experiencing grief simultaneously moves in their acceptance of the loss. Not all individuals will process their grief in this way, however. Some will instead follow a different path leading to chronic and debilitating grief. Grief is primarily thought of as being caused by the death of a loved one, but it has many other causes. For example, loss of identity, loss of safety, loss of autonomy, and loss of dreams or expectations. Loss of identity can be experienced when a client faces the loss of a role or relationship, such as after divorce, when one is no longer considered a spouse, or when a child goes off to college, leaving the parent as an empty nester, or having undergone a double mastectomy, when a client might feel a loss of femininity. Loss of safety is experienced when clients perceive that they have lost physical, emotional, and mental happiness. Loss of security can be experienced when clients find themselves evicted or have an erratic housing arrangements. Among children of divorced parents, or when a survivor of physical abuse fears for their safety on a daily basis. Loss of autonomy is experienced as a result of older adults' inability to take care of themselves and belief that they can no longer contribute to society, or when individuals have a worsening condition that affects their physical or cognitive capability. Loss of dreams and expectations is experienced when an individual's hopes and dreams remain unfulfilled. Examples include clients whose career path fails to mirror their expectations, students struggling to find where they belong in the real world, and a couple who is coming to terms with infertility. Thus, there are many causes of grief unrelated to death, and nurses need to be aware of clients experiencing all sources of grief so they can assist them in working through their grief with support and guidance. Anticipatory grief is defined as grief that is experienced before the loss of someone or something. This kind of grief arises when a loss is expected. A loved one is still living, but a substantial diagnosis has been made. The client's health is worsening or death is imminent. Anticipatory grief commonly occurs when a client has been identified as having a terminal illness or has been suffering from some chronic disease over an extended period of time. This type of grief can be experienced by clients who have a connection with a dying person or are the dying person themselves. As with normal grief, there is no exact amount of time over which a person may experience anticipatory grief. Even though a person has experienced anticipatory grief previously, the prior experience will not affect the present grief experience or the degree of grief an individual experiences after a loss. Clients who suffer anticipatory grief can display both mental and physical manifestations. Common findings of anticipatory grief include sadness, anger, loneliness, guilt, anxiety, fear, fatigue, and poor concentration. It is normal to have this type of grief when someone or something that a client loves is expected to be lost, and clients can experience anticipatory grief when they face a looming crisis or end of life. Prolonged grief disorder, previously known as complicated grief, is grief that lasts longer than 6 months for adolescents and children and 12 months or longer for adults. It can be so significant that it affects the client's ability to function. Clients who are experiencing prolonged grief are unable to accept the death of the loved one. Their behavior is marked by a persistent need to find the deceased person, and they are preoccupied with thoughts of the deceased person. Other manifestations of prolonged grief disorder include feelings of guilt, self-blame, anger, and difficulty participating in new and different activities. It is not unusual for clients experiencing prolonged grief to detach themselves from their friends or family, making it harder for them to recover as they become isolated and lonely. Disenfranchised grief is grief related to a relationship that does not coincide with what is considered by society to be a recognized or justified loss. The loss is considered by society to be one of shame or socially uncomfortable and therefore not worthy of grief. Because the loss is not generally regarded as worthy of grief, social support is not provided to the grieving individual. Clients who are experiencing disenfranchised grief are left to grieve alone and in silence, as compared to clients experiencing normal grief for whom rituals are routinely utilized to lessen the burden after a loss. Disenfranchised grief can occur as a result of a loss being unrecognized as significant, example, loss of a pet or a miscarriage, or unrecognized relationship, example, an extramarital affair, an unrecognized griever, example, a young child, or the loss itself being disenfranchised, example, suicide. In all of these cases, a relationship has been lost, as well as the griever's ability to grieve in public and receive the social support that assists in the grieving process. Clients experiencing disenfranchised grief can suffer from depression, unstable emotions, social isolation, physical symptoms, insomnia, and low self-esteem. Normal grief. This grief is considered uncomplicated. Emotions can be negative, like anger, resentment, withdrawal, hopelessness, and guilt, but should change to acceptance with time. Some acceptance should be evident by 6 months after the loss. Somatic complaints that can include chest pain, palpitations, headaches, nausea, changes in sleep patterns, and fatigue. Nursing interventions for grief. Facilitate mourning. Allow time for the grieving process. Identify expected grieving behaviors like crying, somatic manifestations, and anxiety. Use therapeutic communication related to the client's stage of grief. Name the emotion the client is feeling. For example, the nurse can say, "You sound as though you are angry." Anger is a normal feeling for someone who has lost a loved one. Tell me about how you are feeling. Use active listening, open-ended questions, paraphrasing, clarifying, and summarizing while using therapeutic communication. Use silence and personal presence to facilitate mourning. Avoid communication that inhibits the open expression of feelings, like offering false reassurance, giving advice, changing the subject, or taking the focus away from the grieving individual. Assist the grieving individual to accept the reality of the loss. Support effects to move on in the face of loss. Encourage the building of new relationships. Provide continuing support. Encourage the support of family and friends. Assess for evidence of ineffective coping, a client refusing to leave the home months after the death of a partner. Share information about the tasks and stages of mourning and grieving with a client who might not realize that feelings, anger toward the deceased, are expected. When interacting with someone who is bereaved, avoid cliches. They are in a better place now. Rather, encourage the individual to share memories about the deceased. Provide information on available community resources. Interprofessional collaboration. We can encourage attendance at bereavement or grief support groups. Provide information about available community resources. Initiate referrals for individual psychotherapy for clients who have difficulty resolving grief. Offer to connect a spiritual advisor for the client or encourage the client to do so, and participate in meetings with professional grief and mental health counselors. Palliative care. The nurse serves as an advocate for the client's sense of dignity and self-esteem by providing palliative care at the end of life. The goal is to learn to live fully with an incurable condition. Palliative care improves the quality of life of clients and their families facing end-of-life issues. Palliative care interventions are primarily used when caring for clients who are dying and family members who are grieving, but can be used for any client who has a chronic curable illness, regardless of the stage of the disease process. Assessment of the client's family is very important as well. Palliative care interventions focus on the relief of physical manifestations like pain, as well as addressing spiritual, emotional, and psychosocial aspects of the client's life. An interprofessional team of physicians, nurses, social workers, physical therapists, massage therapists, occupational therapists, music art therapists, touch energy therapists, and spiritual support staff provide palliative care. Hospice care. Comprehensive care for the client and the client's family. It can be provided in a variety of settings such as home, a healthcare facility, or extended care facility, and is implemented when a client is not expected to live longer than 6 months. Medical care aimed toward a cure is stopped, and the focus becomes enhancing the quality of life and supporting the client toward a peaceful and dignified death. This is different from palliative care. Assessment and data collection for hospice care. We determine the client's sources of strength and hope. We identify the desires and expectations of the client and family for end-of-life care. Characteristics of discomfort include pain, anxiety, restlessness, dyspnea, nausea, vomiting, dehydration, diarrhea, constipation, urinary fecal incontinence, inability to perform ADLs. Manifestations of approaching death. This is very important to remember. You will see a decreased level of consciousness. You'll see loss of muscle tone with obvious relaxation of the face. You'll see labored breathing, dyspnea, apnea, Shine-Stokes respirations, which is an irregular rate and depth of respiration that includes periods of apnea and periods of hyperventilation. Go back and look at those in breathing patterns if you need to. Audible respirations due to pulmonary secretions, like sounds like a death rattle. The sense of touch is diminished, but the client can feel the pressure of touch. Mucus can collect in large airways. Incontinence of bowel and bladder. Mottling, cyanosis occurring with poor circulation. Pupils become no longer reactive to light. The pulse can become slow and weak. The blood pressure is dropping. The extremities will be cool. We could see some perspiration. You can see decreased and dark urine output and an ability to swallow. All are manifestations of approaching death. Physiological changes at the end of life follow a familiar pattern of signs and symptoms. The terminal phase of a client's life is characteristically referred to as actively dying or imminent death. Read this slide to see physiological alterations at the end of life. If you didn't go back and look up what Shine-Stokes respirations are, it's an irregular respiratory rate fluctuating between several quick breaths and periods of apnea. As you can see on the slide, the breathing is rapid and then it stops, and then it's deep and rapid and then it stops. You may also hear congestion and gurgling because the person is unable to cough up secretions effectively. We can place the patient on their side or use a toothette to gently clean the mouth of secretions. We can administer medications to decrease the production of secretions. Slowed circulation to the brain may cause the breathing pattern to become irregular with brief periods of no breathing or shallow breathing. For that, we can elevate the patient's head and position the patient on his or her side. Oxygen therapy for dyspnea near death has not been established as a standard of care for all patients. However, those who do not respond promptly to morphine or other drugs should be placed on oxygen to assess its effect. Patients often feel more comfortable when the oxygen saturation is greater than 90%. If possible, provide oxygen by nasal cannula because masks can be frightening. If oxygen is not effective, discontinue it. Medication used for drying out of secretions can help to ease the work of breathing. Other physiological alterations at the end of life could be vision and hearing changes. Clients may experience hallucinations or report hearing and seeing those who have already died. Dignity is regarded as an everyday necessity, essential to the well-being of all clients. Most complaints related to nursing care at the end of life are associated with a lack of caring. As clients near the end of life, illness contributes to a loss of control, which lessens their sense of dignity. A good death. When a client is actively dying, healthcare providers, family, and caregivers are responsible for providing a good death for the client. This generally includes pain management, planning for death, closure at the end of life, clear decision-making, and being able to contribute to others. As nurses, we can provide nursing interventions at the end of life. We can promote continuity of care and communication by limiting assigned staff changes, keeping the same nurses. We can assist the client and family to set priorities for end-of-life care, what's most important to them. As far as physical care, we can promote comfort by controlling manifestations of the dying process. We can administer medications like morphine that manage pain, air hunger, and anxiety. We can perform ongoing assessments to determine the effectiveness of treatment and the need for modifications of the treatment plan, like lower or higher doses of medications. We can manage adverse effects of medications. We can reposition the client to maintain airway patency and comfort. We can maintain the integrity of their skin and mucous membranes. We can provide caring touch, like holding their hands. We can provide an environment that promotes dignity and self-esteem, so we can remove products of elimination as soon as possible to maintain a clean and odor-free environment, offer comfortable clothing, provide careful grooming for hair, nails, and skin, and we can encourage family members to bring in comforting possessions to make the client feel at home. If appropriate, we can encourage the use of relaxation techniques like guided imagery and music. We can promote decision-making in food selection, activities, and healthcare to give the client as much control as possible, and we can encourage the client to perform ADLs as able and willing to do so. For psychosocial care, we can use an interprofessional approach. We can provide care and foster support for the client and family. We can use volunteers when appropriate to provide non-medical care. You can use therapeutic communication to develop, maintain, and facilitate communication between the client, family, and their provider. You can facilitate the understanding of information regarding disease progression and treatment choices. We can facilitate communication between the client, the family, and the provider. We can encourage the client to participate in religious or other practices that bring comfort and strength if appropriate. We can assess the client in clarifying personal values to facilitate effective decision making. We can encourage the client to use coping mechanisms that have worked in the past. We can be sensitive to comments made in the presence of clients who are unconscious because hearing is the last sensation lost. We can discuss specific concerns the client and family might have, like financial or role changes, and we can initiate referrals for services as needed, such as social services. Prevention of abandonment and isolation. We can reduce the fear of dying alone. Make your presence known by answering call lights in a timely manner and making frequent contact. Keep the client informed of procedure and assessment times. Allow family members to stay overnight. Determine where the client is most comfortable, in a room close to the nurse's station. If the client chooses to be at home, consider moving the client's bed to a central location in the home rather than an isolated bedroom. Support for the grieving family. Suggest that family members plan visits to promote the client's rest. Encourage that family members receive appropriate information as the treatment plan changes. Provide privacy so family members can communicate and express feelings among themselves without including the client. Determine family members' desires to provide physical care while maintaining awareness of possible caregiver fatigue. Provide instruction as necessary. Educate the family about physical changes to expect as the client moves closer to death. We've already discussed those. Allow families to express feelings. Nurses are responsible for following federal and state laws regarding requests for organ and tissue donation, obtaining permission for autopsy, ensuring the certification and other documentation of the death, and providing post-mortem after-death care. After post-mortem care is completed, the client's family becomes the nurse's primary focus. Post-mortem care interventions. We have to care for the body. We have to provide with respect and compassion while attending to the desires of the client and family per their cultural, religious, and social practices. We have to check the client's religion and make attempts to comply. We have to recognize that the provider certifies death by pronouncing the time and documenting therapies used and actions taken prior to death. That would be the doctor, not the nurse. We elevate the client's head to prevent facial discoloration by raising the head of the bed and placing a pillow under the head and shoulders. Do this as soon as possible after the client's death. To prepare the body for viewing, we ask the family whether they want to be included in preparation of the body. We maintain privacy. We remove all tubes unless an autopsy is to be attained, organs are to be donated, or this is a medical examiner's case. In that case, you keep all tubes in situ or where they belong and where they were placed. We want to remove all personal belongings and give them to the family. We want to cleanse and align the body supine with a pillow under the head, arms with the palms of hands down, outside the sheet and blanket, dentures in place, and eyes closed. We want to apply fresh linens with absorbent pads on the bed and a gown. We want to brush and comb the client's hair, replace any hair pieces. We want to remove excess supplies, equipment, and soiled linens from the room. We want to dim the lights and minimize noise to provide a calm environment. Viewing considerations. Ask the family whether they would like to visit with the body, honoring any decision. Clarify where the client's personal belongings should go with the body or to be with a designated person. Adhere to the same procedures when the client is an infant with the following exceptions. Swaddle the infant's body in a clean blanket. transport the infant in the nurse's arms or in an infant carrier based on facility protocol, offer the family members the infant identification bracelets, footprints, the cord clamp, a lock of hair, and photos. Post-viewing, we need to apply identification tags according to facility policy, usually the toe and the outer bag. We need to complete documentation and remain aware of visitor and staff sensibilities during transport, meaning we need to be respectful when we're transporting that patient to the morgue. Organ and tissue donation, we need to recognize that requests for tissue and organ donations must be made by specifically trained personnel. We have to provide support and education to family members as decisions are being made. Use private areas for any family discussions concerning donation. Be sensitive to cultural and religious influences. Maintain ventilatory and cardiovascular support for vital organ retrieval. Autopsy considerations. The provider typically approaches the family about performing an autopsy. The nurse's role is to answer the family members' questions and support their choices. Autopsies can be conducted to advance scientific knowledge regarding disease processes, which can lead to the development of new therapies. The law, though, can require an autopsy be performed if the death is due to homicide, suicide, or accidental death, or if death occurs within 24 hours of a hospital admission. Most facilities require that all tubes remain in place for an autopsy. Documentation and completion of forms following federal and state laws typically includes the following: who pronounced the death and at what time, usually a provider, consideration of and preparation for organ donation, description of any tubes or lines left in or on the body, disposition of personal articles, who was notified and any decisions that were made, location of the identification tags, and the time the body was left the facility and the destination. Care for nurses who are grieving. Nurses may encounter many challenges in providing support to those who are experiencing grief and loss when a client dies. Sometimes their formal education may have included limited training in assisting families at the time of death or loss. Most nurses at some time in their career will experience grief from a personal loss. Many will find themselves in a position where they will be required to support family members or other loved ones who are experiencing grief and loss. Nurses are responsible for providing and expected to deliver compassionate nursing care to both clients and their families. To ensure they are capable of delivering the best care for those experiencing grief and loss, nurses must need to remain emotionally balanced while caring for clients and families experiencing grief and loss. Nurse self-care when caring for the grieving client and family. Nurses may experience grief after a client's death. Their reactions may differ in the way grief is expressed, however, and are affected by the clinical circumstances of the client's death, as well as personal factors specific to the nurse. Some grieving nurses may display anger, depression, irritation, or helplessness. Nurses may experience grief after a client's death. Their reactions may differ in the way grief is expressed, however, and are affected by the clinical circumstances of the client's death, as well as personal factors specific to the nurse. Some grieving nurses may display anger, depression, irritation, or helplessness. I know in my personal experience, I have often felt helplessness, especially in younger clients or clients with a disease process that can't be cured. Self-care. A plan for self-care begins with nurses performing a self-reflection and evaluation of their current state of being. In performing a self-evaluation, they may want to take a holistic view of their life, including their physical, psychological, spiritual, relationships, and financial status. Once the evaluation is complete, each nurse can identify areas in which opportunities for growth exist and work on those areas. For example, physical movement, self-care activities might include eating healthy, getting regular exercise, and maintaining a healthy weight. Psychological improvement can be attained through use of relaxation and imagery techniques, reading books, and engaging with groups that facilitate happiness. Spiritual self-care is achieved through participation in activities such as joining a religious group that develops the higher self, practicing meditation, or yoga. Economic self-care includes living within one's financial budget. Psychological self-care activities focus on participating in activities that stimulate one's mind through creativity and play. Recognizing personal grief. Grief can be exhibited through various emotional and physical manifestations, including anxiety, difficulty sleeping, headaches, and joint pain. The majority of findings are psychological. Nurses need to find a place that is supportive of their feelings and where they can heal. Keeping emotions to oneself and not dealing with them can cause nurses to be less effective in providing care for their clients. Nurses, like clients, need to verbalize and process feelings of grief. As part of this healing, they need to set aside time for themselves and make taking care of themselves a priority. The American Nurses Association's Code of Ethics states that nurses have a duty to take care of themselves as they do others, including health and safety, preserve competence, protect their character and dignity, and continue personal and professional growth. Self-care relieves stress that is associated with being a nurse, restores the ability to be compassionate and empathetic, and promotes safety and higher quality client care. Strategies for self-care focus on maintaining a healthy body and mind, including eating a healthy diet, participating in physical exercising, socializing with family and friends, and getting adequate rest. Compassion fatigue. By its very nature, nursing practice focuses on showing compassion when caring for clients and their families, and forming emotional relationships, such as when caring for a dying client. Nurses find themselves repeatedly caring for clients who are suffering and injured, and as they care for them, they share in the pain and suffering of those clients. Compassion fatigue is defined as cumulative stress that develops from the desire to help those who are suffering, combined with the inability to relieve that suffering, which results in a feeling of professional uselessness and self-blame. Certain types of nursing specialties, emergency room, critical care, and end-of-life care, are at increased risk of compassion fatigue. Findings of compassion fatigue include difficulty in focusing, feeling nervous, anxiety, disruptive behavior with coworkers, and problems connecting with clients sympathetically. Strategies to prevent compassion fatigue include reflective journaling, participating in continuing education activities to restore the mind, and engaging in non-nursing activities that reduce job-related stress, such as meditation, spiritual practices, reading, going to the movies, spending time with family and friends, and exercising. You have to figure out what works for you to deal with the stress of caring for people that sometimes you are unable to help. When you care for a client in a long-term setting, you can develop personal attachments. Nurses can use coping strategies with consideration of professional boundaries, such as going to a client's funeral, communicating in writing to the family, attending debriefing sessions with colleagues, using stress management techniques, and talking with a professional counselor. These can be effective coping strategies to deal with the stress of grieving your patients. Summary: grief is the pain experienced after significant loss, typically the death of a loved one. It is a sensation that is felt when someone or something that a client loves is lost. Grief can be experienced after any important loss, for example, a divorce, retirement, joblessness, financial instability, a miscarriage, the end of a friendship, or moving to a new city. Grief is usually accompanied by physiological stress, separation anxiety, disorientation, longing, thinking about the past excessively, and nervousness or anxiety about the future. Normal grief, also known as uncomplicated grief, is caused by the loss of someone very close through death or the ending of a relationship. Other causes of grief include loss of identity, loss of safety, loss of autonomy, and loss of dreams or expectations. Anticipatory grief is grief that is experienced before the loss of someone or something. This type of grief can be experienced by the client who has a connection with a dying person, or the dying person can experience anticipatory grief. Prolonged grief disorder, previously known as complicated grief, may be experienced by clients who are unable to accept the death of a loved one. Their behavior is marked by a persistent need to find the deceased person, and they are preoccupied with thoughts of the deceased person. Disenfranchised grief is grief related to a relationship that does not coincide with what is considered by society to be a recognized or justified loss. Grief theories and models have been developed to provide explanations and guidance in anticipating how a person may cope and adjust in experiencing grief and loss. One of the best-known grief theories is Kubler-Ross's 5 stages of grief. According to this theory, individuals typically experience 5 stages during the grieving process: denial, anger, bargaining, depression, and acceptance. These stages are not sequential, and an individual may not necessarily go through all of them. Common manifestations of grief include crying spells, difficulty sleeping, changes in food intake, and decreased productivity in the work setting. Culture may provide guidelines for how people express their grief experience and, in turn, serves as the foundations of their actions. Religious, spiritual rituals can help a person who is grieving to deal with death and the grieving process. Religion can provide comfort during the grieving process by providing the knowledge of what supposedly comes after death. As the nurse assists clients and families experiencing grief and loss, the goal is for those involved in the grieving process to verbalize their feelings and have a reliable support system. Nurses, like clients, need to verbalize and process their own feelings of grief. Nurses need to take time to care for themselves and make self-care a priority. Compassion fatigue is defined as cumulative stress that develops from the desire to help those who are suffering, combined with the inability to relieve that suffering, which leads to a feeling of professional uselessness and self-blame. Certain types of nursing specialties, emergency room, and end-of-life care can increase the risk of developing compassion fatigue.